My name is Gavin Perkins. I'm a Professor of Critical Care Medicine at the University of Warwick and University Hospitals Birmingham. I'm going to talk to you today in the CPR session in relation to drug management of cardiac arrest. I need to share these conflicts of interest to you, which predominantly focus on my role as the Chief Investigator of the Paramedic 2 trial that was funded by the National Institute for Health Research, and also my volunteer roles with the European Resuscitation Council and the International Liaison Committee on Resuscitation. Drug therapy forms part of the universal treatment algorithm for cardiac arrest and follows the initial assessment of the unresponsive patient and the initiation of CPR and defibrillation. For patients in non-shockable rhythm, drug therapy is given as soon as vascular access can be obtained, whilst for patients that present with initially shockable rhythms, the focus is initially on defibrillation before considering the use of drugs after the third shock has been unsuccessful. Before moving into focus on the detail of the evidence in relation to the use of drugs in cardiac arrest, I'd just like to remind you about the importance of the chain of survival and parts prior to the administration of drug, the early recognition of cardiac arrest being 10 times more effective than drug therapy, early bystander CPR having 8 times greater effect than drug therapy, and the significant role that defibrillation, early defibrillation plays in optimizing outcomes, being 20-fold more effective than adrenaline. In terms of the use of vasopressors, adrenaline is the main drug recommended for the treatment of cardiac arrest, and the primary evidence in relation to adrenaline comes from the Paramedic 2 study that I had the opportunity to work with some outstanding colleagues in the UK from South Central, West Midlands, London, North East and Welsh Ambulance Service. I'm grateful very much for the support also from the National Institute for Health Research for providing the funding and infrastructure to deliver the trial. The trial was a placebo-controlled trial that compared adrenaline against saline placebo amongst 8,000 patients that had sustained an out-of-hospital cardiac arrest. And I'd just like to draw your attention to some of the details of the study. The study focused on patients that were refractory to initial attempts at resuscitation, where registry data report a survival rate of 3 to 4% because those who respond to initial resuscitation attempts weren't eligible to participate in the study. In terms of the outcomes of the study, adrenaline was 3-fold more effective than placebo at restarting the heart, similarly leading to a 3-fold higher increase in hospital admission. There was also a 0.8% improvement in survival to hospital discharge, although at hospital discharge there was no significant difference in the proportion of patients who survived to go home from hospital with a favourable neurological outcome. Moving forward from hospital discharge, a similar pattern is seen at 3 and 6 months follow-up. There's a sustained increase in survival at 3 months amongst patients that received adrenaline, but no significant difference in the proportion that survived with a favourable neurological outcome at either 3 or 6 months. When looking into the study in some more detail and undertaking this meta-analysis with the other randomised controlled trial, the PACA trial led by Ian Jacobs in Australia, one can see that the effect of adrenaline is more pronounced in patients that have an initially non-shockable rhythm. This slide presents the data for return of spontaneous circulation, having a 6-fold increase in return of spontaneous circulation. A similar pattern is observed in survival to hospital discharge, with the effects being more pronounced in patients presenting with an initially non-shockable rhythm as opposed to those with a shockable rhythm. And a similar pattern for favourable neurological outcome, although you'll note that the pooled estimate, the confidence interval, even from the meta-analysis of these studies in both shockable and non-shockable rhythms, crosses 1. I think one of the key considerations or lessons to take away from the use of drugs, if one accepts that the impact of adrenaline on long-term survival is a significant and important impact, then looking at this study, which was some follow-up work drawn from the Paramedic 2 study, which looked at the time to drug administration. And whilst it didn't find a differential effect, in favour of adrenaline compared to placebo in relation to the time to drug administration, what it did show is that the earlier treatment is given, irrespective of the form of that treatment, the greater the chances are of survival. And if one extrapolates it, I think that the message from this piece of research is around the importance of giving drug therapy as soon as practicable. We've gone on to explore the economic impact of adrenaline in the Paramedic 2 trial, and these are the typical cost effectiveness planes. The within trial cost effectiveness analysis demonstrated increased cost without any improvement in quality adjusted life years. One can see, if they model and extrapolate that to a lifetime horizon, that the cost effectiveness plot moves towards the top right, but still doesn't reach the threshold that most health systems would consider as a cost effective therapy, as indicated over on the right. By contrast, if one includes the indirect benefits of organ transplantation, then the cost effectiveness plane shifts further over to the top right, and the probability that adrenaline therapy is cost effective moves into the threshold that most health funders would consider using. Now, the information presented has been synthesised by the International Liaison Committee of Resuscitation, who recommend the use of adrenaline during cardiac arrest and provide a strong recommendation for that based on low to moderately certain evidence. They recommend that adrenaline is used as soon as feasible for non-shockable rhythms, and again provide a strong recommendation for that. For shockable rhythms, they suggest that adrenaline is given after initial attempts at defibrillation are unsuccessful, and that comes as a weak recommendation with very low certainty evidence. Reading the task force insights into the discussions provides some explanation for the position that the ILCOR has taken, and in making the recommendation for the use of adrenaline during CPR, they note that the findings with adrenaline compared to placebo substantially improves the rate of return of spontaneous circulation, hospital admission and survival to hospital discharge. And it's on this basis that they made a strong recommendation, given that the intervention may reduce mortality in a life-threatening situation and the adverse events were not prohibitive. And they place a very high value on an uncertain but potentially life-preserving benefit. They, however, note that the impact on neurological outcomes remains uncertain, with no statistically significant evidence of benefit or harm through to 3 months. Moving on then to consider the use of antiarrhythmic medications. The main body of evidence for antiarrhythmic drugs come from Peter Kudenchuk and colleagues' study, the ROC ALPS study that was conducted over in the US. This study, which was published in the New England Journal of Medicine, had the primary outcome of survival to hospital discharge, and you can see in the overall analysis that there was no significant difference in either the primary or any of the secondary outcomes that compared amiodarone lidocaine with placebo. However, in the predefined subgroup analysis for this, whether the cardiac arrest was witnessed by a bystander versus unwitnessed, one can see that there is a significant interaction favouring the use of both amiodarone and lidocaine compared to placebo for patients that have a bystander witnessed cardiac arrest. with there being no effect seen in those who sustain an unwitnessed cardiac arrest. This led to the recommendation from ILCOR that suggests in favour of the use of amiodarone or lidocaine in adults with shock refractory ventricular fibrillation or pulseless ventricular tachycardia. The ILCOR Consensus on Science and Treatment recommendation also addresses the use of magnesium, and on the basis of the randomised evidence identified, they suggest against the routine use of magnesium, and make no recommendation in relation to the use of botulinum or other antiarrhythmic agents on the basis of there really being very limited evidence to support or refute the use of those drugs in cardiac arrest. So looking then at the use of pharmacological therapy, this was a large observational study from the States. One can see that antiarrhythmics are used in between 5 and 10% of patients that sustain an out-of-hospital cardiac arrest, and adrenaline is widely used. In the context of a 12-minute presentation, there's not the opportunity to go into the evidence, or indeed the lack of evidence in relation to the use of atropine and bicarbonate, other than to note that there really is no compelling evidence to suggest that those drugs should be used in the during the routine management of patients that sustain out-of-hospital cardiac arrest. So I hope in the 12 minutes available for this presentation, I've provided the opportunity to update you on the use of pharmacological therapy as part of the Advanced Life Support treatment algorithm, and to have walked you through some of the underlying evidence that underpins the treatment recommendations in relation to drugs and cardiac arrest. Thank you very much for your time and attention.